So Dr. Hoppy, if you don't mind, come over here. We'll sit down here and then we can start the panel discussion for a couple of minutes until you bear with us, and then we'll go for coffee and sweet.
So let's start the discussion.
Thank you very much. Okay. So panel discussion, blah, blah, blah. Great. So we can start. Any of you guys have any comment, or should we open for questions? Okay, please start bombarding us with questions. We gave a lot of information here, so I'm listening. Okay, one by one. We cannot handle all these, okay? Okay, Marcus is good.
Very simple question. Maybe you were mentioning before, Virgil, the number, the particle switching is quite fast. So what are the numbers there you can envision or are already known?
I cannot give you a precise number for the moment because the machine is still under installation and will be under commissioning. But we expect for ions to ions or heavy ion switching, few seconds. Yeah.
And proton to ion?
No, this is a bad question. No, proton to ion it's something tricky for a machine because, as I was showing, proton extraction is different. So, of course, the switching proton to ions will take much more time. We're talking about 10 to 15 minutes. But ions to ions, this will be quick. Yeah.
Thank you. Next question.
For tumor apoptosis, do you think that the number of fractions by hadron therapy will reduce compared to the photons that we do right now, or even protons? And time duration.
Dr. Hoppy, maybe you can say something and then we can comment.
Yeah, can I call a friend, maybe Piero? Yeah, so I think the question is about whether we'll get to even more extreme hypo-fractionation with carbon ion therapy. And I think, I think this is an area of great interest. Obviously, help the throughput of patients, allow us to treat more patients. I think we've seen certain indications in Japan where they're doing things in just 1 or 2 treatments. And so I think as we learn from our colleagues, at least in the US, as we learn from colleagues in Japan and Europe, we'll be very intrigued by potentially going to a more hypofractionated treatment.
I think that it should be a must to have a hypofractionation because of economics and sustainability of these centers. I mean, the cost of carbon facilities are very high. And if we don't exploit at best these options, let's say treating more patients, this is becoming a problem.
Yes. So before Piero, so what? If you guys remember, I was talking about the ultra-personalization. Ultra-personalization means you deliver a kick, you watch, biology responds, you get the markers. The markers will tell you which way you're going. Immunotherapy, immune cells are coming in. Don't kill them, wait, etc., right? So this is the tools of hadron therapy, proton therapy, photon therapy are there, and they're just like made. These systems are made to do ultra personalization. Now, what exactly is the time, between pulse 1 and pulse 4? That's one of the variables that I listed. We don't know today. We don't know today. You have some indications, and then fundamental researchers, this is like a lots of information that they can do. Identify the marker, watch it, and then zap it again. So that's the idea, right? And again, easy to say, difficult to do because you need data. But that's why we live in a sexy times, because we can actually collect all this data. Hence, on the animals you can collect 1,000,000 times more data because animal is not going to complain when it's at sleep. And then on humans you can collect some, and then AI makes the bridge. Dr. Piero.
Yeah. Brad was calling me. you have to consider that most patients will get one cancer, maybe two cancer in their life. And for them, 1 week more, 1 week less is not a difference. And that is our priority number one. So of course, the manager will try to push you to treat more patients with less fractions. But the doctor should resist if the only reason is economics. We should do it if the reason is better treatment. And I think that state of the art now is very difficult to go lower. Head and neck, you have significant toxicity in the mucosa. Big sarcoma in the pelvis, you have significant toxicity in the nerves. Rectum, pancreas. But there is a way forward. And the way forward for me is linked to LET painting. If you put the high LET in the tumor and out of the organ, then you have the possibility of further reducing the fractionation because you dramatically decrease the toxicity. So I think as we are now, we are basically there. I don't think, I mean, even in QST, they have this very long tradition of reducing the number of fractions. For prostate, they are at 4, but I'm not aware, please, Dr. Yamada, tell us, they are still doing 16 for head and neck, for big sarcoma, because it would be scary to do less than that. If I may, another topic. You were mentioning PULSAR, you were mentioning type 3 indication, and we heard from Dr. Inaniwa how important is the resensitization. We could think of carbon for radiosensitization rather than a full course. And that would be small number of fractions, that would be along your PULSAR concept, and that would be relying on already existing quantitative data. I think it is a very promising way of thinking, just an initial boost to make the rest of the treatment more effective.
Great, thank you very much. All great comments.
Just to follow up on that, we actually have one of our clinicians, Dr. Dan Trifoletti, who's a CNS expert. He has a little project that he's trying to work on for GBM, where he wants to do a pulse of, he's doing photons and protons, and then hopefully carbon, and then they go to surgery. So they'll have the specimen, and then afterwards receive their further radiation. So I think a lot of people have that concept in mind too.
This is fantastic. So the message from here is build as many centers as possible. Yes, please.
So just one question. You mentioned that just look for the marker and then treat according to the marker. But what markers do you want to use?
Yeah. So the answer to that is today we have no clue. So we have no clue. That's why initially, okay, we propose take everything that I can. Some comes for free. Some comes with some sort of input, right? Free comes. Take a bunch of images, take samples, take blood, take urine, take everything, right? Then analyze, dump it to the AI, and AI is made to actually make sense of this. Human is not. I will never be able to go through all this, you know. But today we live in a world where dump it into AI, and then in a year or two, AI will say, good job. You try to collect, 150 of the features. I'm sorry, out of these 150 features, 50 are garbage. Forget it. Okay, and the other 50 are predictive. And that's what we are aiming at. That's what we are zooming for. Find the predictive ones that have prognostic value. Okay. But we're beginning.
This might be a dumb question, but I thought the difference between the heavier particles and photons decreases as the fraction size goes up. So if we're doing 1 or 2 fractions, then on the tumor, the effect is going to be similar to X-rays. Maybe the penumbra might be sharper, but can somebody explain why we would want to go to extreme hypofractionation with carbon?
Because we're collecting data. So the answer is you don't know. I mean, in the realm of PULSAR, you don't know. In the realm of PULSAR, you put it in, you put a kick, you watch, and then based on this, you steer the ship. You put another one, you watch, and at some point you might say, out of 5 fractions, I don't need 5. Maybe I end up at 4.
But that approach would be similar to carbon and photon.
Exactly.
I mean,
agree.
So I'm wondering in particular about carbon, the benefit of extreme hypofractionation. after a certain point, besides the penumbra?
Yeah, I can't answer that. I think we have others in the audience that might be able to. I think there's the radiobiologic concerns, and then there's the clinical data that we've seen in Japan for successfully treating some patients with 1 or 2 fractions. But I don't know if someone else in the audience, more expertise in this, wants to comment.
Beyond the clear one, which is even if it's the same, it's a win. If 16 fractions does the same as 8 or 4, you're still winning, right? For the patient, it's a benefit.
As long as you're not compromising local control.
Yes.
And maybe it's not entirely true that the difference becomes negligible. So you have this data we have seen from Dr. Yamada yesterday, that the high dose per fraction will reduce the RBE, but more for the healthy tissue than for the tumors. So in that sense, and the other point of Anita was, yes, but if you give a very high dose per fraction, then you don't need carbon. Is it really so? Is that the high dose per fraction we are giving with SBRT taking care even of the most radioresistant subcomponent of the most radioresistant tumor? I think not. So it's not like we are giving single shot of 100 gray and then yes, okay, there will be no difference.
And compared with photons, obviously you have the ballistical selectivity as well, so a better tolerance due to this advantage. But it's true that high dose per fraction means less RBE as far as tumor and normal tissue, but there is a differential effect, and you spare better the normal tissue than the tumor.
Right. More questions? More discussion topics? Yes, please. How do we foresee, I repeat, how do we foresee, and I missed the question. Oh, spatial fractionation. Oh, yes. So the question is, is there any reason to, or what's the connection between spatial fractionation with carbon ion therapy? Anybody wants to answer that? Certainly not a physicist. You guys are doing, interesting things in Medostron, so maybe you want to say something about Slava's results.
I would say it's a very interesting research topic. That's my.
So the answer is yes. Medostron is exploring this, and again, that's in the exploration type. Collect the data, see what you've done, and as long as you haven't done worse, you are in the right path. Anybody else? Well, in that case, thank you all. This was great, and coffee is waiting.
Yeah, and we'll be back for 11:30 for the next session.